So, who am I? So I'm a number of things, and actually we've been talking about multiple personalities in sense of multiple roles and personhood this morning already. So the multiple positions I hold, and these are some but not all of them. I'm the mother of 2 children. They both have a diagnosis of autism and ADHD, sensory processing, anxiety. We're a service user family as well as, you know, being a service provider as well. Myself, I have diagnosis of epilepsy. I'm dyslexic. I have auditory processing disorder. And I would say I've got lots of neurovariety, probably. Connor, if he's still here, he'd tell you I'm most likely autistic. Given the family history, probably am, but I don't have a diagnosis that's formal. I have diagnosis by Connor. I mean, that's one thing. I previously worked as the neurodevelopmental team lead in a children's service, looking at autism assessment and ADHD assessment. Currently, I work as a clinical director in a children, family and all age service in the UK. I'm also the CAMS provider collaborative lead, so looking at how services can work together. I'm a systemic psychotherapist. I'm still in practice. I qualified a number of years ago. I was talking to somebody in the break about how I'm still nervous when I meet a family, as if I'm the same as when I was newly qualified, really. I'm the daughter of a mother who has cerebral palsy, so we grew up knowing about the ability and disability, really, and understanding about being different. And I'm also, well, I was a doctoral researcher looking at autism diagnosis, mothering girls. Can I just check everybody can hear? There's something in the chat saying people maybe can't hear. Is everything okay?
I can hear you fine, Mary.
I can hear you too.
Yes,
I can. Okay, so it might be something with Emma's. Can somebody just pop something in the chat to Emma just to check that she's okay? That'd be great, thank you. So I'm here to talk to you today about developing a neurodiversity strategy, which is something that we have been doing in Berkshire Healthcare. It connects with some of what Connor was saying about making a difference, and it connects with some of the questions that were asked really about what can we do. We can make differences in the moment with the people that we meet, with our clients, with our, you know, the families that we work with, but we can also make a difference as wider systems as well, or we can hold the systems we work into account to do something the same. So in April 2021, we made a commitment to develop, implement and embed a trust neurodiversity strategy. And it was aiming at addressing the health inequalities, both physical and mental health inequalities that exist for neurodivergent service users. And that was about, you know, diagnosed or suspected. And what could we do to improve patient experience and make all of our services more effective, efficient, and to drive quality? It was looking at the care and treatment of people of all ages who accessed our services. And taking into account, somebody mentioned in the chat earlier about not them and us, but only us. And that's the kind of approach that we wanted to take with our strategy. We look at supporting our neurodivergent workforce and engaging with the equality and diversity agenda of our employees and also our potential employees. And we were also acknowledging that the people who work for our services can also be the people that access our services, like myself. So I'm just going to ask you just to take a moment and to think about this question, and then maybe pop a few things in the chat, really. What narratives are held about neurodiversity, especially autism and ADHD, in the agencies that you work for or within? I'm just wondering if people wouldn't mind just thinking and just popping a few things in the chat. So other, yeah, so there's that idea that people are other. Complex, yeah, I think that was a comment earlier, wasn't it? Not understood. oh, they aren't spoken of, not qualified enough, no imagination or empathy. Neurodiversity is for adults and not for children, not for adults, I mean, sorry. Gosh, lots of things. Lack of awareness. We are not skilled to help them. Out-of-date understandings. Yeah, lots of different things, really. These are some of the things that I've come across in my work about people in organisations. So that old chestnut, anxiety in the context of autism, I've seen that written quite a lot. So, you know, if you're anxious but you're autistic, then there's nothing anyone can do about it. You've got to live with it. It's just being autistic. Autism and ADHD is childhood conditions. So, you know, what happens to grown-up people? You know, do they kind of just disappear off the face of the earth? Mental health services don't accept autistic people. So, you know, the story about somebody's challenges being because they're autistic, not because they have other mental health needs, and they don't need other support around mental health needs. You need a diagnosis to access support. So there's people waiting to go to services, but because there's a question about whether they're autistic or not, there's a delay whilst they're waiting to get their diagnosis or not. But then you can't access a service if you have a diagnosis. So there's a load of other people who can't access a service because they've got a diagnosis. There's kind of like no winning here. It's a real double bind. Autism and ADHD is something mental health services need to know about, but not physical health services. It's not something that you need to know about if you're just providing acute hospital care. People with autism and ADHD need to see specialists in autism and ADHD. And neurodivergent people are service users, not service providers. So these are some of the unhelpful narratives from and about services around neurodiversity and autistic people. So one of the things we wanted to do with our strategy was challenge some of those narratives and stories. And I've been really interested lately in the idea of how we use stories for change. And I'm looking at something at the moment from Ellis Altmarsh. Story is light, so illuminating what is happening and what is possible. And I hope that some of what we do today and tomorrow in the conference is just that. It's illuminating what's happening and what's possible. Story is glue, so a way to cohere communities of change makers. And then story is web, so changing the nest of narratives in which we live. Again, that's something I hope that we can sort of bring about today as we have these conversations together. So what do we mean by stories as light? So story helps illuminate the past, present and future, helping it light up the path of change. Specifically, it highlights the fault lines in a system and it makes reasoned cases for change. It illuminates outliers and it builds a coherent narrative around people's work, and it shines a light on visions of the future that change the way people act in the present. So with this strategy, and people were talking earlier about the NHS and kind of data and figures and numbers. And actually, I think sometimes you need to enter the grammar of the services that you work within. So with the NHS, if things like data and numbers are the figures that kind of sort of galvanise people into action, what can we do to use that grammar to kind of engage with the leaders in organisations to show them that stuff around neurodiversity isn't just because we think it's important, it can be important to them as well in the language they understand. So data and research told us that national data around life expectancy is that, you know, autistic people are expected to live 20 years less than neurotypical people. We had data in our services on suicide and serious incidents and self-harm. Now, if you work in the NHS, you will know that they don't like serious incidents. We don't want there to be serious incidents. We need to learn from them. We had waiting time data. People were waiting too long for services. And people are accessing services as well. National data tells us that neurodivergent people have higher rates of unemployment Now in the NHS, we've got issues around not being able to recruit enough people. And neurodivergent people stay in our mental health inpatient wards 30% longer than people who are neurotypical, particularly people with autistic people. So this is the kind of data that if you work in the NHS, we'll start to get your directors and your leaders listening, actually, because if we can get some of these things right, it becomes more cost effective as well as making services better for the people that access them and provide them. We spoke to patients and their families, so more qualitative data. They told us that we needed to understand autism and ADHD better. We need to give clearer information and we need to communicate better. We need to reduce waiting times. And they also told us that they had difficulty accessing services due to sensory needs. So this is hearing from the people that matter, and it's connecting it with the data of the service providers that matters to them. And then staff told us that they were worried about discrimination. And this is the people working for us who are autistic, who have ADHD, who are neurodivergent in some way. They were telling us that they were worried about discrimination if they told others that they were autistic. They also told us that they were worried that they would be judged and it would have an impact on their career progression if they told others that they were autistic or had ADHD or they were dyslexic. People also didn't see neurodivergence as a disability, so they didn't declare it on staff recording forms like ESR. So that meant that people didn't know how many people they had working in their organisation who were neurodivergent. So really, we're starting to see a place where, people aren't getting such a good service, and also people who are providing the service don't feel so supported if they're neurodivergent. So that's what we're doing, we're highlighting this story. But then also, we want to illuminate outliers and build a coherent narrative around people's work. So what were people already doing that could make a difference? What were the pockets of good practice? So existing training on autism, adapting therapies and improving support for people waiting. So these things were all happening. So in terms of shining a light on visions of the future that change the way people act in the present, we worked towards a new sort of vision in our strategy. And our strategy vision was for everybody in Berkshire Healthcare to recognise, understand and celebrate neurodiversity, of all neurodivergent people working in or using our services to be empowered and enabled to have equal access to effective services, support and fulfilling lives. So this is our new story. And then story is glue. So story is a tool for building community through empathy and coherence. It enables people to connect across difference and to generate narratives that hold together groups, organisations and movements. So we started to combine narratives. So we were connecting the strategy, vision and goals across the rest of the trust. So staff events, sharing stories, declaring, our own CEO declared to the 300 members of staff that he was dyslexic, and that was something he'd only ever told about 2 or 3 people before. Hearing from experts by experience, like people like Connor talking about their experiences. And we started to combine new stories with existing narratives, so connecting strategy aims with trust targets such as weights, workforce risk, service user feedback, improving clinical services, reducing incidents, financial sense, all the things that matter to certain groups of people. And we can use story to reauthor the web of narratives we live in. So specifically, we can use it to change the personal narratives that we have about our lives, change the cultural narratives that frame the issues we advocate for, and change the mythic narratives that influence our worldview. So changing the personal narratives, it was moving from them to us. And then services as the problem, not neurodiversity or my husband's just brought my water in there. God bless him, thank you. Services as the problem, not neurodiversity as a problem, or neurodivergence, ADHD or autistic people as the problem. And then stories about how we can change, not how others should change to fit with us. So in terms of changing cultural narratives that frame the issues we advocate for, it was shifting problem narratives. So hard to reach families, not hard to reach patients. So hard to reach services, not hard to reach families. And then what did data tell us? Which services have we failed, which services have the most failed appointments from neurodivergent people? What's that telling us? And a call to action to services to improve their own delivery and accessibility rather than focus on what's missing elsewhere. And then also weaving with our other networks. So thinking about our race equality network, the Pride network, Purple network, we have a Courage network. So we've got an event coming up where we're gonna all combine and work together, thinking about intersectionality. And data, challenging narratives about autism as childhood condition. So we're using sort of connected care data. So it's data that has GP data, trust data, all this together to start to look at neurodivergent people within our services. So this is a bar chart that shows the number of people who are currently diagnosed as autistic. So if you see, there's the age of diagnosis is still relatively young, and their age today, but there's a wave. So it's showing people, that wave shows that these people are going to access adult services. Also that there's more than likely that number of people undiagnosed currently accessing adult services as well. And then changing mythic narratives that influence our worldview. So pre-existing stereotypes and practices, making autism and neurodiversity everybody's business and not just children's services or mental health services. So adult mental health, adult physical health, all of our children's services, things like podiatry, dentistry, every service, everybody needs to know about autism and ADHD, not just one or two specific services, connecting with what Connor said earlier. So we had stories that were told and stories that were heard. I think I might go over soon, so I need to hurry up, don't I? So understand autism and ADHD better, we were told, give clearer information and communicate better. So we have a neurodiversity lived experience advisor, Tanny, who I think is with us today as well, which is fantastic. We have training by experts by experience. We're developing guidance on written communication, guidance on terminology. There's been the development of a neurodiversity passport that will go on people's clinical records that talks about how they identify. I prefer to be called autistic. I prefer to be, referred to as someone with autism. How people like to communicate, their sensory needs, all these kind of things, and it will be connected to their records, and that will travel with them. And we also have a Trust Neurodiversity page with information on it for staff. And then stories told and heard. We have difficulty accessing services due to sensory needs, and then we had increased numbers of incidents for neurodivergent people on our wards. So there's been sensory reviews of the hospital wards. We've got our estate colleagues working with us to highlight the importance of the sensory environment. And when they develop new buildings, they've got a checklist around sensory. And they've got kind of a toolkit when they think about refurbishing new buildings. Other stories that were told and stories that we've heard. So reduce waiting times and reduce barriers to services or support. And someone said, I always felt that I didn't meet the threshold for instance, compared to those with serious health conditions and physical disability. So developing data dashboards to highlight weights and access to all services, partnering with researchers to profile strength and support needs, regardless of diagnosis for our workforce, and then working collaboratively across services to design new assessment pathways. So what can we do to reduce waiting times? And other stories told and stories that have been heard. Staff were telling us we're worried about discrimination. We're worried about being judged and the impact of our career progression. So we have staff events, we have neurodiversity pin badges celebrating neurodiversity within the trust. We're promoting reasonable adjustments and anticipatory adjustments. Developing neuro-inclusive recruitment practices, so everybody getting the questions before an interview, for example. So it's not just singling one person out either, but it helps everybody. Senior leaders identifying as neurodivergent, so everybody being able to say comfortably and confidently, I'm neurodivergent, I'm autistic, I've got ADHD, I'm dyslexic. This is what it means to me. And then social media posts and our staff neurodiversity page. So that's some of what we've been doing. I suppose it's thinking about how we connect storytelling with strategy and how we can make change as a wider system as well. And I suppose it's to invite you to kind of, as a call to action within your services, if there isn't something similar, could they develop something the same, for example?